Hello, everybody. I'm Dr. Kelly OMD, your board certified OBGYN and healthcare executive, here to help you live your healthiest and wealthiest life. You have entered the Ask Dr. Kelly OMD Zoom room, and we have our special guest coming back, Dr. Ebony Hoskins, who is a gynecologic oncologist. She's going to let you know what all of those words mean. But just to say, the last time she's here, she dropped jewels, and telling you this time she's about to drop gems. So, Dr. Ebony Hoskins, let us know the top 3 things you want us to know while you tell us a little bit about yourself so we can go ahead and get started.
Thank you so much for inviting me back. I'm so happy to be back and share this wealth of knowledge that I have. So as Dr. Kelly mentioned, I'm a gynecologic oncologist, so board certified OBGYN trained, and then additional 3 years of training in gynecologic oncology. So what's gynecologic oncology? Cancer below the belt. Uterine cancer, endometrial cancer, ovary, fallopian tube, have to always think of them, cervical, vaginal, all those kind of lady parts, if you will, is what I specialize in. And so tonight I wanted to give you 3 points and then we'll start it off. One is that endometrial cancer is on the rise. When I first started training, I will never forget that the quoted number per year of diagnoses was 40,000. In 2024, it is 67,880 uterine cancers. So you ask yourself, like, wait, I thought we were supposed to be like going down in cancer incidence. And no, actually this cancer is on the rise. The other thing is that Black women are 90% more likely to die of the endometrial cancer compared to white women. And my third thing is there is no screening test. I think a lot of people think that, oh, well, I had my pap smear, and that was fine. The pap smear screens for cervical cancer, the cervix. I wish I had a picture. But anyway, that's the entry of into the womb, if you will, or the uterus, is the cervix, which is a totally different organ than the endometrium. So that's where we're starting.
Well, we all know that we're about to get some great education, interactive understanding, and we're ready for you. So go ahead, Dr. Hoskins.
Okay, so the reason why I really wanted to talk about it is because the cancer is on the rise. And I think the biggest thing is like, well, why is it on the rise? One is we see a direct correlation with obesity. So obesity is on that trajectory. I don't have our slides, and we don't need them to know that as obesity rises, so is endometrial cancer. And it's largely thought to be hormonal. And so that hormone, if you will, is an estrogen-like hormone that can stimulate the endometrium, just like estrogen can stimulate the endometrium, if you remember back to the menstrual cycle. And so when we see endometrial cancer, we typically, not always, typically see it in women who are after menopause, so postmenopausal women. But you can see it in premenopausal or even perimenopausal women, so women who have not gone through through menopause yet. And largely the symptoms are, we'll just go with postmenopausal, no bleeding for a year, if they have any abnormal bleeding after menopause. Or really, I think it's worthy to be evaluated if there is abnormal bleeding and someone has not gone through menopause. That is worthy of being evaluated. Yes, we have things like fibroids. Yes, we have things like hormonal changes, quite honestly, that can cause abnormal uterine bleeding or abnormal menses. But I do think that you go 1 or 2 months and it's abnormal, they should be evaluated. And who can evaluate? I always go back to that. Who can evaluate? I think it's okay to see your primary care doctor. I am biased and I feel like a GYN doctor is probably the best, but I do recognize that we are in a time of where we don't have access to providers. And so let's be really real that the access is limited. And so if you can get into a primary care doctor and you can be evaluated, that's great. OBGYN as well. And how we evaluate for abnormal uterine bleeding or postmenopausal bleeding is with ultrasound and an exam. So getting your history, finding out what's going on, getting a family history. That's another thing that we can talk about. Getting an ultrasound to evaluate the endometrium or the uterus, or, all the organs down there, if you will. And then sometimes we have to go and do a biopsy. And the biopsy could be something that's done in the office or an outpatient setting in a surgery, or sometimes you have to go to the hospital. But I'm not saying that it's all bad. I just want to be that folks are aware of what things that is going on. What I hear a lot, stop me guys, if you know, Dr. Kelly, if you have any questions, because I will just go on and on and on. So please direct me.
It's okay. They're used to like listening and then asking the questions. But Viva Lifers, if you have questions that you want to start dropping in the chat, then that can direct the conversation as well.
Okay.
But we're going to get those, other two major points out, and then we can
Yes.
go on from there.
Okay, so the next point, I think we talked about the number on a rise, and what else did I tell you? Higher risk. So I think the reason why Black women are more likely to die, we have a couple of ones that make sense, but then I think overall, I don't have a good grasp on it. One is being diagnosed at a later stage. So that means disease is no longer confined to the endometrium. It is now spread outside of the endometrium of the uterus. Maybe it's in the ovaries, maybe it's in a fallopian tube, maybe it's further away, so distant spread, if you will. And Black women are more likely to have more aggressive histologic types. So I was telling Dr. Kelly that, when I used to work in a totally different community, really predominantly white community, it would be the stage 1, confined to the uterus, surgery is all you need, you're cured. And then I moved to a community where I'm taking care of Black women, and it's stage 3, stage 4, aggressive histologic type. I'm giving chemo, I'm giving radiation on a regular, which is totally different than even when I trained. So like the question is, what's causing it? I don't know. There has been some theory. Is it related to perms? And I can't go into all the detail of that yet, but I will say that maybe it is. I just don't think we have all the data to support it. And then the last thing in terms of the expanding my point is there is no screening test. So being in tune with your body, any type of abnormal uterine bleeding, postmenopausal bleeding, things don't feel quite right, making sure that you are seeing your GYN or your primary for your annual PAP and or pelvic exam is essential. Keeping in mind, the PAP does not screen for for uterine cancer. Now remember, uterine cancer, and maybe I didn't explain it, endometrial cancer in particular, is cancer of the lining of the uterus, whereas cancer of the cervix is a cervical cancer. We have PAP tests for that, an HPV test for that, but we don't have that for uterine cancer. So those are kind of my highlights. The other point I wanted to point out is there are some genetic causes. So things that you may or may not be aware of, Lynch syndrome. These are family syndromes where you may see high risk of colon cancer, is also associated with endometrial cancer. That can be largely prevented if there's genetics testing in the family.
Yeah, I think you make some great points there. Thanks for bringing up the genetic piece of it, because we have had our, resident gastroenterologist on here, and we put those two things together, that there's genetic pieces that are associated with like a family of cancers as well. The fact that just going back, breaking it down, and I know we've talked about on it before, and I know most of the people on the line actually have these organs or had these organs at some point in their life. But really just breaking it down, that the outside of what we call the vagina is called the vulva, the lips. And then we talk about the entrance into the vagina, which is a tube. And then when at the end of the tube, there's a cervix, and that's the little donut that people are aware of. And then inside of our body is our actual uterus, tubes,
Right.
and ovaries. So, that's where we're talking about this uterine cancer. It looks like a balloon. Your uterus, for the most part, looks like a balloon. Granted, 60 to 80% of women, specifically Black women, probably more than 80%, have like Mickey Mouse ears and everything else on their uterus because they have fibroids. But, those are kind of that's the anatomy. And like you mentioned, when you talk about the screening. So the screening for pap smear for your cervix is the pap smear. There is not a screening for your uterus, except for if you have irregular bleeding, or after you stop bleeding for a year, which is called menopause, postmenopausal, you have bleeding after that. That's the pretty much screening that we have. We don't just automatically do ultrasounds on women every year. We don't
Right.
automatically do a sampling of the inside of the uterus called an endometrial biopsy every year. First of all, that hurts. And second of all, we probably have a lot of false positives, but potentially in our population, that might be a different type of thing. So thank you so much for breaking those things down for us. And I
Mhm.
know we have people on here that are OBGYNs, that are nurses, that are non-medical and medical. So I want y'all to start dropping your questions in the chat in regards to that, or come off mute and ask the question. We are not a shy group here, so don't be shy, because this is something that can affect you or someone you know.
Or
So
family member. I think the one thing I want to keep in mind, and that what we see is that there's been studies on it, like there's been delays in care, and some of it has to be education. And so we're here to talk about it, and also to realize when you talk to a girlfriend, she's like, oh yeah, I'm having this abnormal bleeding, that you actually bring it up. And it's actually not taboo to talk about it and to educate. I hear women all the time that say, oh, I haven't gone through my period. I'm still having my period. And I'm like, wait, you're 60. That's abnormal. So like making, being aware so that we can make it not taboo and to talk about it. So please, I'm here to talk if you have questions.
So that being said, what are your recommendations? I know what the recommendations from ACOG and American College of OBGYNs, as well as the CDC, as far as how often we should be getting our well woman exam, our annual exam. I know things have changed, but from a gynecologic standpoint, what are your recommendations?
So, I will put that out there, and it kind of goes into another topic, but pap smears aren't, again, that's looking at cervical cancer, go according to risk. And the biggest risk we know is having HPV. In terms of having pelvic exam, I'm going to be biased and say they need to happen every year. There is I think it's the Institute, one of the internal medicine organizations said, oh, you're after 65, you don't need a pelvic exam anymore unless you're having some type of symptom. And I disagree, because there's still organ there, right? They don't disappear at age 65. And I've met several women, there are doctors who said, oh, you don't need an exam anymore. And they had cancers develop, and they just thought at 65, they were done.
Yeah, not the way folks are living till, trying to live their best life until they're 75 and 85. So I love that answer. And I too agree that you should have a well woman. And when I tell people you need a head to toe exam, somebody needs to listen, look, and feel your entire body.
I agree.
And
Should we take some of the questions in the chat?
yeah, so my mother-in-law died of endometrial cancer. What lifestyle changes can a family adopt to help lower the risk developing uterine cancer, particularly for my daughters? So thank you for asking that question, Cheryl.
I think one question I will look at, so we already talked about obesity as being a direct correlation for increased risk for endometrial cancer. So maintaining a healthy weight and lifestyle, what's healthy? We would say not being in the obesity range in terms of BMI. Dr. Kelly can expand on that, on what's healthy, but in terms of that, so decreasing risk for things like diabetes and hypertension, obesity. And I will also encourage you or whoever is in the family is to take note to see, are there other folks in the family who may have been affected? A lot of times you find the family doesn't want to talk about it. So maybe you find out later, well, her brother had colon cancer and somebody else had a GI cancer. Perhaps there should be genetics. That's the most proactive we can be, is getting genetics testing if there's a high risk. And again, who's going to help you decipher that? Primary care provider, gynecologist. Those are going to help kind of decipher. So genetics testing, healthy lifestyle, potentially.
I love that. Now, question, because reproductive age women are more times than not placed on different forms of birth control. What is your perspective, as well as kind of the evidence on the protective factors of certain types of birth control or non-protective factors?
I don't know. I'll be honest. I don't think I can speak on the fact of combined birth control. I mean, I guess it probably could be protective. I just can't speak on that. What I can say is IUDs, progesterone releasing, particularly like the Mirena, can be protective. We actually use it to treat precancer. So endometrial hyperplasia, or someone who may be, let's say she wants to have a baby and has an endometrial cancer and she meets criteria, we will treat with IUD. So I think a Mirena or progesterone releasing IUD potentially can be protective. Again, is there any randomized controlled trial that is saying, hey, we gave these women all IUDs and these women didn't? We don't have that, but we can assume that decreases the risk based off of the mechanism of action.
Yes. And then you're talking about healthy options. So as far as a healthy lifestyle, what I tell people is don't try to look like me, but try to make sure that you're eating as clean as possible. So minimizing those white carbs. And people are like, well, what are white carbs? So I'm talking about white bread, doughy stuff, milks, things like that at an excessive amount, trying to reduce those things. Even white rice, big thing that we can reduce. So if it's white, then you're more likely than not going to need to decrease that amount for you. And let's see, we have another question. Is abnormal bleeding the only sign? And can I ask for a sonogram as part of my annual physical?
That's a good question. I would say abnormal bleeding is not the only sign, it's the most common sign. I would say 70% of women have either postmenopausal bleeding or abnormal uterine bleeding if they're still menstruating. Can a transvaginal ultrasound be used as an annual? I would back away from that because it is not found to be a screening test. So what you're saying is, can they order it for screening test? It is not a screening test. Can we order it if there are abnormalities on the exam or abnormal symptoms? Yes, I think so. Because what we find, if you start ordering all these tests, you find stuff, and now you had an unnecessary procedure because they saw a little polyp, or, we don't always have to operate on everything that we see. So combining symptoms or signs that your doctor finds, I think can prompt an ultrasound, but not routinely ordering ultrasounds. You're going to end up with an unnecessary surgery, most likely.
Absolutely. So one of the things that that is talked about a lot is fibroids. But what we don't talk about is the fact that, okay, specifically women of color have higher incidence of fibroids. But we don't talk about the uterine cancer portion of it. Like, how do we know that this fibroid is not uterine cancer lurking?
You want to know the real answer?
Uh-huh.
I mean, we truly don't know, right? So I think one thing I would like for the group to know is uterine cancer, uterus includes the muscle of the uterus. So the outer part, the muscle, that's where your contractions and cramping come from. And then the lining, the shed, where we shed and bleeding, that is the endometrium, if you will. If a fibroid is concerned for cancer, those are called sarcomas, which is actually 10% of uterine cancer in kind of its own separate entity. But in terms of how do we know that beforehand, a lot of times we don't know. We can look at the characteristics on ultrasound. MRI is probably the best tool that we have. And still, I've seen MRIs do, take a look at it and they still can't really tell. So that one is a hard. Does everyone who has fibroid have leiomyosarcoma? Absolutely not. Most likely they're fibroids, but I think having a discussion with your GYN provider and getting additional imaging and assessing the entire situation will help determine. A lot of times we don't know that diagnosis beforehand.
And I think, thank you for that answer. And I think the honest answer, thank you. That's the important part is that we definitely talk about, honestly, what happens in that clinical experience, because we want people to be very much educated and aware of what the possibilities are. So that being said, if somebody is diagnosed with endometrial or uterine cancer, let's just say uterine cancer in general, what are some of the things that they should, well, first of all, as providers, how should we really present this to our patients? And second of all, what are some of the things that patients should be asking about? What's the process once I get this diagnosis?
Okay, so most of the time the diagnosis comes from, I would say, GYN doctor, because, or, I would say mid-level, because now we have multiple different type of providers who've done a biopsy beforehand, and they will refer to a gynecologic oncologist. So the subspecialist within our specialty. And by that time, I would say the GYN provider says, look, hey, I see a cancer here. I'm going to send you to the gynecologic oncologist. At that consultation, and I tell folks this all the time, our number one tool for diagnosis and management upfront is surgery. So when they're coming in, the anticipation is that there's going to be a surgery. And then I will have to admit, I've seen more recently where I can't take them to surgery because it's widely metastatic. Now, listen, I'm not saying that to scare anyone. It's just what I am seeing in my short 13 years of practice. That's been a change. And I feel like I don't know what's going on. So that being said, surgery is usually that. And we need all the information to tell us the stage, the type, and a treatment plan, a comma. I'm saying it like I'm dictating. Surgery, if necessary, right? So I don't know all the information until I get all the tissue and look at all the tissue and come up with a treatment plan, stage, the type, and a plan. The positives that I will say is 10 years ago, we had like if someone had advanced endometrial cancer, we had one treatment and that was it. And after that, we didn't have anything else. In the last 5 years, we are making a lot of progress. It may not seem like a lot, but for us, I have 2, 3, 4 more options that I did not have easily 5 years ago. So there's being more efforts from the governing bodies, the United States government, who, provide grants from pharmaceutical companies into the need for treating endometrial cancer. So I'm going on my rant. Sorry.
No, we appreciate that because you're the subject matter expert, and it's great to know that we have more than one option as far as, once you have surgery, or if you choose not to have surgery, there's some other options potentially that are available for you. Mm-hmm. Gold standard is to remove it. However, if you so choose not to, then there's other options. And we have a question from Sheila. Come off of mute for us and go ahead and ask your question, please.
My question is, I live in Mississippi and we have a very high obesity rate. I have diagnosed patients with endometrial cancer or even cervical cancer and so forth. And the problem I have is that because of the supermorbid obesity that we see, a lot of these patients are not surgical candidates. And how do we treat these patients? And if we're treating them with medication and asking them to lose weight, what length of time do we give them to lose weight?
I struggle with that, what you just told me. Mm-hmm. I don't believe in that. So it makes me question the providers. I understand that they're obese, but I feel like we got to try to get them to surgery, right? And so my question is, there disparity? We won't even go into that, okay? But I will say that I'm going to try to get these patients to surgery because I know, one, they're going to do better with the actual stage and diagnosis and to have it out. If these are Black women, that makes me really pause in terms of what kind of care is being given. Real talk.
So let me, because there are a couple of OBGYNs on here that I know that are trying. So the question is, from what I can understand, if you have a super morbidly obese patient and you say you're trying to get them to surgery, what are you doing, Dr. Hoskins, to get anesthesia, cardiology to sign off? Because it's not just us as the OBGYN.
I know. I'll be honest, and I'm gonna, maybe this is biased, but I think it's unacceptable to allow the treat them. You got to be like, she's going to die on the table type of clearance, not just because of weight. So sure. Guess what? Sometimes an IUD or progesterones is not going to help an advanced endometrial cancer.
So can we do
someone who has a grade 3 endometrial cancer?
Right. Can we do the medications that are out, the semaglutinides and everything like that? Are we able to put them on a regimen of potentially high level MEGACE or, I know people do that, but that's only for, or can we get them on the semaglutide and say, okay, in the next it's not going to work in 6 weeks, but in the next 3 months, are we able to do something significantly?
Honestly, I've never done that. Okay. I don't know, that data is out there is missing. Again, what I know is surgery. So I'm like, even when I have patients who are morbidly obese and probably the highest BMI I've taken a surgery is like 60, 65, they're up there. That's what we have the robot for.
Mm.
I'm trying to get them to surgery because I know that that's going to make a difference. If they can't get to surgery, like they truly can't be just weight. It's got to be weight, heart, all these other stuff. Sure, we can talk about it, but we know that that's less superior, really. And whether, putting them in injections and the time frame. And again, I'm going to be biased because I know that when I see the Black women, they don't have the type where you can throw IUD in and sit.
Mhm.
That's
Yep.
not what I see. So it makes me anxious. So the tools that I'm thinking is, hey, where can I get her to get in to do a robotic surgery? And I know that it may be it becomes a dilemma if they're in rural area and there may be an access issue, it gives me angst.
So Sheila, what have you seen people do in this situation? Like, give us an example of what you see people do.
What I've seen, and having referred to a GYN oncologist, I've seen them where they would put them on megas. I've seen where they sent them to a nutritionist and so forth to help them lose weight. I had a 30-some-year-old G0 that had been bleeding abnormally, and I diagnosed her. I got the biopsy and diagnosed endometrial cancer. And she did lose weight, and she got her surgery and also a paniculectomy at the same time. And she was, very appreciative and has done well. But I've also seen the patient that you've taken to the OR to get a diagnosis that anesthesia had difficulty ventilating that patient, with a BMI of 68, and then trying to get them to have an additional surgery for their cancer without weight loss. So I see it all, and we try to do the best that we can for the patient. And I understand that there are these disparities out there, and there are biases and so forth, especially in seeing obese patients and so forth. But on the same hand, I also see the struggle that some of the surgeons have.
Oh, it's real.
It's real. So, but those are
like I try, that if I see that patient, the BMI coming up, I know it's about to be a hard day, but I know I got to get it done. Like I'm going to try, so.
And I think one of the important pieces is helping the patient understand this is a significant risk. You not having surgery is a significant risk. You having surgery is a significant risk. These are the risk benefits that we have right now. These are the percentages. But one of the things I tell my patients is the possibility of dying or having a complication from any surgery is there. Let's talk about that risk and let's see what we can do to help prevent that. And if if there are location centers of excellence that are able to work with a patient when they have the BMIs above 60 or towards the 70 range, if we can find those and get those people to them in the meantime, as well as doing the nutrition, as well as the mental and emotional support that they need in order to be able to live through this and to be successful and thrive, then I think that we all would try to do that as well. So it's good to know, who is our center of excellence that can get us to BMI of 60, BMI of 70, and then how do we get the patient there and who's going to pay for it? Because unfortunately, there is an insurance issue. So whether it's a state insurance or not, I think those things come up as well. Sheila, great question.
Great. Yeah, you do the best you can, but it's hard.
Awesome. Anybody else have any questions? I know this is a conversation we don't talk about a lot, but if we had a couple of things just to take away, I'm sitting in church or I'm at a concert or whatever, because I'm that person that will ask you, when's the last time you got your well woman exam done? But I'm a GYN. But honestly, Dr. Hoskins, if you are, sitting next to people and having conversations, what kind of things should you really bring up and say to them to say, you know what, we need to get this done, checked, and how do we practice proactive prevention?
I think that's a great question. One, I don't always bring that up, but I saw a patient the other day. Patient had uterine cancer, had Lynch syndrome. The daughter, I said, hey, have you been tested? Yes, I've been tested. Are you positive? Yes, I have Lynch syndrome. Oh, you're 42. Are you done with childbearing? When are you going to get that hysterectomy scheduled? So in terms of the genetics part. So if there's conversations in the family and not just for uterine cancer, but hey, there's a strong cancer family history. We're doing a lot more genetics. Sometimes surgery or having the genetics test is the best thing we have to help prevent. So those are things and conversations that we can have that may not seem so personal, if you will, in terms of, what's going on down there. But, asking about the genetics with a family member at Christmas, at a holiday, that kind of stuff. I think we should make that normal. And even like I felt the patient's daughter, I think kind of did not like me asking it, but it needed to come up because later she's going to come back and need help. And I think we can be kind of prevented. So, I think my other take home point is, I don't think pelvic exams ever end. We should continue. We hate them. Yes, we hate getting them, but we should have somebody just check in on us.
Absolutely. I can't see inside. I can only feel inside. So
yes.
Well, we truly appreciate you being here, Dr. Hoskins. Like I said, not only did you drop jewels last time, you dropped gems this time because I learned something. And if I could call this a CME, I would.
Oh, gosh.
Is there any way that if we needed to refer somebody to you or be able to get in contact with you, how would you like us to do that?
I think I'm not big on the social media part on that aspect, but email. Yeah, I'm happy if you would like to share my email, or you want me to put it in the chat.
Sure, if that put it in the chat, because then we'll put it in the chat. And then if you have patients that are in the Maryland area, the DMV area, then a wonderful GYN oncologist who's going to keep it real for you. So, and that being said, did anybody get anything out of this educational experience today? I hope you say yes, because I know I learned a lot and I really appreciate it. And we really appreciate each one of you. So I'm Dr. Kelly, OMD, your board certified OBGYN. This is Ask Dr. Kelly, OMD. You can follow us on all your social media platforms at Viva Life Health Hub. Have a wonderful day. And don't forget to do what? Viva Life. All right. Thank you for being a part of the Viva Life experience. I'm Dr. Kelly OMD, board certified OBGYN and healthcare executive. If you like what you heard, then please go ahead and like, share, and subscribe. The reason why is because we are trying to educate, encourage, and inspire 1 million people to live their healthiest and wealthiest life. And this is what we're bringing you. We're bringing you educational videos. We're bringing you podcasts. We are bringing you webinars with subject matter experts, including myself, about the topics that affect you the most. So go ahead, like, subscribe, and share. We are everywhere. Have a wonderful day. Viva Life.